There's a person here that says they've got a patient, a friend who is almost vegan, little eggs and fish, gags, and she tries to eat meat, doesn't want to eat animals. She's chronic digestive issues, bloated stomach, no muscles in her arms, sunken eyes. What advice should I give her? She also has poor bone health, damage to ribs getting into a car. I don't know. Do you have any advice for people trying to convert vegans into eat?
You'll probably appreciate this as much as anybody, Sean. I actually see a disproportionate amount of vegans in my clinic, and God only knows why. They're often in for a shock. The big problem is, I ask people, why are you vegan? The people who say I'm vegan for my health, they are absolutely the easiest, because it's very easy to prove objectively with lab testing and examination, investigation, so on and so forth, that their diet is hurting their health. No problem, we fix that. It's all a matter of education. The people who are ethical vegans, I think, are the next easiest to fix, because that is also a matter of education. It takes a lot longer. I usually recommend Leah Keith's book. And I usually start off with something like, are you open to new ideas? And everybody wants to say, I'm not closed-minded. Sure, yes, of course I am, doctor. Of course, it's like, great, here's a book. It's called The Vegetarian Myth. It is a meticulously referenced tome, and I think it strikes a very sympathetic balance between the psychological rationale for commencing a vegan or a vegetarian diet, and while still having a very dispassionate view of the science. It is all evidence-based. And multiple patients I've had have actually read that and sort of come around. The hardest group of people are these who seem to have a psychological aversion, whether it's through this continued indoctrination against meat or what have you, and they describe this incredibly visceral response to meat consumption. It makes me gag. I physically vomit. Now, I personally think that this is evidence of probably a bit of psychological issue as well. And I think that it is able to be overcome, but it is certainly difficult. And those consults go for a long time. And we usually talk about graded introductions. And I find that approaching it from a belief perspective and an ethical perspective probably seems to be most helpful, because what a lot of people don't realize is there's probably these underlying beliefs that is being manifested in these overt physical behaviors. But it is difficult, and I would recommend Leah Keith's book as a first port of call on the understanding that it is a relatively sympathetic. Now, for some people who have these health problems who are never going to stop being vegan or vegetarian, a book like Stephen Gundry's Plant Paradox, I think, is reasonable, because it does address some of the toxicities of plant-based foods. And while being completely and utterly biased against meat and animal products, I think it addresses important concepts that if you're going to continue consuming these foods, there are ways that you can make them safe. We can seed, we can ferment, we can cook them on high temperature, moist temperature for a long period of time, and potentially we can take these supplements which will actually bind to the damaging lectins before they get digested and prevent, or at least reduce some of their deleterious effects. But at the end of the day, some people, this is almost a religious doctrine, and some people are just not going to be convinced, and we just have to accept that we can't fix the woes of the world on our own.
All right, this is a question from Michelle, and then I want to bring it back to autoimmune and gut health. But Michelle's just asking a question: if someone's got our osteoarthritis, should they limit weightlifting if they're experiencing no pain, lifting slowly with good form?
So I'd say no. So we know that osteoarthritis. So the way osteoarthritis damages is if you grind a joint, you can actually have little fragments of cartilage. This smooth cartilage. So let's go back to what cartilage is. So if you get a soup bone or a dog bone, on the end of the bone, you've got this smooth, shiny surface. That's articular cartilage. That's super smooth, super hard. So two sheets of articular cartilage sliding against each other have less friction than two sheets of wet ice. This is pretty good stuff we're talking about. If that protective surface gets ground down, that's effectively the diagnosis of osteoarthritis. And if you break some of these molecules away, these little particles, they will actually inflame the inside of the joint. in the same way that we traditionally think that gout will, and you'll often get a delayed inflammatory response. So that's, if people are wanting to know, is an exercise bad for them? It's not just whether you get pain during the exercise, but it's whether you get a delayed inflammatory response that will be indicative of having some of this articular cartilage debris coming off. And that usually means you're feeling worse or sorer the next day. So I'll actually use your morning symptoms waking the next day to titrate your exercise levels. And it might be that you reduce the intensity or you reduce the volume or so on and so forth. And in some athletes, what I've actually done when I've been trying to talk them into retirement, like I'll go, these are professional athletes getting paid good money and they really have no other career options. So we tend to push them a little bit harder than we otherwise would. I'll actually stick a needle into the joint after the day after the game and get the fluid, and then we'll put it in the centrifuge and spin it down. And we can actually see these cartilage fragments actually collecting at the bottom. And when we send it to the lab, they'll say, yep, that's definitely articular cartilage. If you're in that situation and exercise is doing that to your joint, you should stop that exercise. But in general, you might have resilient articular cartilage that is not being broken down by the exercise. And this is where the concept of mechanotherapy comes in. And basically mechanotherapy says that when we stress a tissue, the tissue will actually increase in strength so long as we don't overload it. So if we take mechanical force away from a tissue, we send people into space, they come back, they have osteoporosis, they have weak bones, and we take them out of the shuttle in a wheelbarrow basically because their tissues have weakened. But if we have controlled amount of exercise, controlled amount of force on the tissue, it will strengthen. And articular cartilage is exactly the same. So we have a cell called a chondrocyte, which is effectively the main cell in the cartilage. And around that, the periphery, we have something called an extracellular matrix. And the extracellular matrix is what actually confers the mechanical properties to that connective tissue. And if we put on regular force at the right threshold that's not breaking it down but loading it, that extracellular matrix will get stronger and more resilient to compressive and shear forces. So if you are able to exercise and it doesn't hurt during the exercise and it doesn't hurt the next day, in effect, you are benefiting and strengthening your remaining articular cartilage. That is a good thing.
All right, good point. All right, so let's just on autoimmune disease. You are a fan of, well, we've had Chavitoth and Sophia Clemens are big on the PEG 400 test. They feel that gut permeability has a vital role, like Alessio Faisano out of Boston Children's, in the development of autoimmune disease and probably a whole host of other things that we show up with. And I know you've had some. I mean, you test your patients for that. You monitor them. I think you use fecal calprotectin. What is the protocol? How do we manage? How do you manage autoimmune diseases? And with diet, with other things, how do you measure it? What are you doing with regard to those types of things?
A couple of key pillars. So let's get the simple ones out of the way. Good amount of exercise, good amount of safe sun exposure, and that's a whole conversation in itself. But it's got to be safe. But good amount of safe sun exposure. And there has to be a sufficient amount of sleep. And we're not talking 7 hours, we're talking 8 hours plus. Then it comes to things like personal care products. So you can have toothpaste with something like carrageenan in it, which is known to increase intestinal permeability and a bunch of these kind of things. So you have to look at what you're putting into your body, what you're putting onto your body. I've just seen shampoos that have wheat protein in them. If you had psoriasis and a dysfunctional skin barrier, that's going to be absorbed into your body. You're using this toothpaste with carrageenan, that's going to be a problem. Some soaps are going to be problematic. So we know that lipstick is often contaminated with gluten. Well, guess what happens to your risk of the autoimmune disease lupus in females who use lipstick? It's near doubled. So we have to be very careful about what we put on our bodies and in our bodies. And then we come to food. And as a really simple summary, certain foods, mostly having plant-based lectins, have the potential to exacerbate or trigger autoimmune disease. So it really comes down to either an absolute elimination of these plant-based lectins or a trial elimination of these plant-based lectins. And then to further muddy the waters a little bit, there are some arguments you can make against certain dairy and egg whites. And for some people, you just really need to do elimination-based diets and then trial-graded reintroductions. And you can pretty quickly work out what diet they function best on.
Somebody's saying, somebody from Australia, do you have a toothpaste of choice in Australia? I have no idea what brand you have.
I don't do sponsorship. No, not really. Look at the label.
All right. Hey, what about, let me just, for the last couple of minutes here, can you comment on oxalates? There's a lot of concern in the carnivore community about oxalate dumping. We know that obviously oxalates are associated with renal stones. There's some people that will say they are responsible for much, much more than that. What are your thoughts on oxalates in general?
I think they can be, well, certainly we know renal stones are a big cause. I think oxalate arthropathy, certainly joint inflammation, which has previously been undiagnosed. We often will, if somebody has what we call episodic arthritis, for instance, we'll often stick a needle in, suck the fluid out, have a look under a microscope, and we'll say, oh, there's uric acid crystals, you have gout. Or we might say, well, you might have a condition called calcium pyrophosphate deposition disease. And traditionally, we've thought that this abbreviated CPPD is being very fastidious crystals that are hard to see under a microscope. The thing is, I suspect that when we're saying we're assuming these crystals are there, we just can't see them, I think we're probably looking for the wrong thing. And I think oxalate deposition is probably one of the major causes. And the literature coming out will certainly support the fact that oxalate arthropathy is far more widespread than conventional medical teaching would have you believe. And I actually work with a neurosurgeon, and we've just started, when we actually remove, say we're doing a spinal decompression or something, and take out a ligamentum flavum, a ligament in the spine that often causes compression in the spinal cord. We're sending it to the lab, and we're about to do a study where we're, we often see CPPD in the past when we've looked for it specifically, so now we're going to start looking for oxalate crystals. And I think it'll be interesting to see what kind of, when we actually start looking for it, what we're going to find. I suspect we'll start seeing it more and more.